Good evening and a very warm welcome to everyone. Myself, Neetu Abraham, Community Manager at MediSage. MediSage is a platform made by the doctors for the doctors, created to foster continuous knowledge sharing, meaningful learning, and professional collaboration. On behalf of MediSage, I am delighted to welcome you to SexMed Connect to Sexual Health Ki Pathshala Episode 2, where today's focus will be on cognitive behavioral therapy. Now, I would like to invite the MOC Dr. Shama Sultana and Dr. Sindhu Lakshmi to carry forward the session. Over to you, ma'am.
Thank you. Hello everyone. Welcome to SexMed Connect's Sexual Health Ki Pathshala episode 2 with the topic Cognitive Behavioral Therapy Sunita Menon. Before going into the session, we shall once know about SexMed Connect Forum. SexMed Connect is a forum for ops kind initiated by Dr. Neeraj Jadhav sir as a president, Dr. Apurva Datta sir as a vice president, and Dr. Shama Sultana as a secretary and joint secretary, Dr. Naisar. There is a WhatsApp group where we discuss and learn sexual health topics and cases. We have various other social media platforms like Facebook, YouTube, and Instagram, where all updates and material about sexual health shall be available. And I request all the delegates to post their queries in the comment section available at their screens. And at the last of this session, all queries shall be answered by our speaker. So now I invite and welcome our eminent faculty, Ms. Sunita Menon ma'am, who shall be giving a clear knowledge about CBT, that is cognitive behavioral therapy. So madam have did her masters from Swinburne University of Technology, Australia in professional counseling, and she specialized in CBT. She is certified sex therapist from Buehler Institute, US. She is in private practice in Chennai with over 10,000 hours completed of counseling. She treats both individuals and couples. She is a LGBTQI plus affirmative therapist. We are grateful to have you here, ma'am, and we welcome you for this session.
Thank you. The pleasure's mine. Neetu, what am I supposed to do? I share the screen or?
Yeah, ma'am, you can share the
I can
screen
share.
and start your presentation.
Okay. Done. Okay, so I'm straight away going to go into CBT, the full form of CBT. All of you know that's cognitive behavioral therapy. C stands for cognition, B stands for behavior, because the entire premise of CBT is based on cognition and how it can impact the way we behave and the way we feel. So essentially, the way I think will influence the way I behave and the way I end up emoting or feeling. So first, sexual health. I'm going to go, there are a million, zillion definitions of sexual health, but I picked the WHO's definition, which says that sexual health is a state of physical, that's where you guys come in, but also emotional, mental, and social well-being of an individual related to sexuality. And that's where therapists like me come in to deal with the emotional, mental, social well-being component of sexual health. And therefore, it is not merely the absence of disease, dysfunction, or infirmity. So it's very important for us to remember this, that with CBT, we are not dealing here with dysfunctions and disorders. That's your forte. But someone like me, a sex therapist or a CBT therapist, we are dealing more with the emotional, mental, and social aspects of sexual health. So before we get into cognitive behavioral therapy itself, it would be nice for us to just pause and ask ourselves, this is us looking inward actually. Even before I talk sex, or even before I get familiar with what CBT is, how much of my own worldview of sexuality, sexual health, am I familiar with? And we call that the sexological worldview. So all of us in CBT, we believe that there is this triad, TRIAD. So the triad means the way I look at myself, the way I look at the other person, and the way I look at life in general, or the world at large. So all of us are influenced by the triad, myself, the other person, and life in general. So it's very important for us to put into context, what is my world view of sexual health? So sexual health would include one's values, one's beliefs, one's opinions, attitudes, and concepts specific to sexuality. So, sexuality, besides sexual health, will also include sexual orientation and even gender identity. So, which means the entire spectrum of sexual behaviors and identity. So, we have to be all encompassing. So, what are some of the questions I would like for you all to ask yourself? I mean, this is a very personal journey, right? The first one is, growing up, what was my source? Where did I get information from about sexuality, about sexual health? Was it from newspapers, or was it from pornography, or was it from magazines, adult magazines, or was it from my peers? Was it from my parents? Or was it by some kind of a sexual abuse, sexual molestation, or some kind of a negative experience? Where did I get information about sexual health and sexuality? That's the first question you need to ask yourself. The second one could be, today, what is my own attitude to sex? And how important is sex to me? Because this, to a large extent, remember the triad. How do I view sex? What is my attitude to it is definitely going to play a large part in how I view the attitude or the importance of sex for the other person, or for life in general, or world at large. The third one is, of course, we need to also dip into our experiences. What is my personal sexual experience? How has it been for me? We don't need it to be brash, or we don't need to be shy, but to be in touch with our own sexuality is important, and for us to introspect about what kind of sexual experiences have I had. And the last one, of course, which I believe is the most important, because you could have gotten your information from the right source, you could have a very healthy attitude towards sex, and you might have had very healthy sexual experiences. But if you do not have a level of comfort to talk sex, to discuss sex, then the entire exercise with your patient becomes futile. Just sharing my own experience, my professional experience in my clinic. When a client for the first time walks in, I have what we call the first intake form. And in the first intake form, standard questions, of course, about their, I draw the genogram of their family tree, and then I also check in about their physical health and, about their habits, what we call the body budget, like what time do they wake up, and do they keep themselves hydrated and exercise and all of that stuff. But then the last bit is sexual health. I make it a point at the very beginning of the session to check in with them. And I do that deliberately because in my training with Bueller Institute, this is what we were told. We need to ask. If you do not ask, they do not tell. So break the ice and speak about the elephant in the room by simply asking very pertinent questions. May I know what your sexual orientation is? We cannot and we must not at any point assume what their sexual orientation is. So the respect and the dignity we give is ask them, may I know what your sexual orientation is? And then I also offer a disclaimer where I say, I am so sorry, but I do not like to assume. And then you will find that most people are willing to be honest and give their sexual orientation if they are alone with you in the session. The second question I ask them then is, if they tell me they are bi or gay or somewhere on the spectrum, then I also ask them, hey, would you like to also tell me what your gender identity is? It's only then that I go into it. And then, of course, the next question is I ask them about, in their opinion, do they have any sexual dysfunction? Because I'm not a doctor, and many of my clients are not doctors. So I always ask them, in your opinion, do you think you have any sexual dysfunction? And then the third question is, Are you sexually active? So, how do we define sexually active? Assuming they are heterosexual, then my question to them would be, have you had penetrative sex in the last 90 days? Now, that's it, just three questions, but it talks about the elephant in the room. You've broken the ice, and suddenly your client, in your case, patients, know that, hey, she's not shy talking about sex. And I can bring up issues about my sexual health later on in the session because she seems okay with it. Hmm? So this first bit about you getting familiar with your own self and how you view sexuality and sexual health is an important component. So, what are some of the barriers that we find doctors or any clinician has with regard to sexual health and sexuality? Remember, all my slides are going to be about cognition, about how we think, because we are in CBT. Yes? So, the first barrier we find that most people tend to have, clinicians, doctors, therapists, talking about sex is, hey, am I going to be violating a boundary? Am I going to be asking a very personal issue? So just fear of violating a boundary stops us from asking, as in my case, three very pertinent questions: sexually active, any sexual dysfunction in your personal opinion, and what is your sexual orientation? So trust me, you're not violating a boundary, you're asking for permission and you're asking them as in the implicit model. The second barrier to comfort is not that the client or the patient is uncomfortable, but we are uncomfortable. So the barrier is us ourselves, where we feel very self conscious and we are almost embarrassed, especially if the client or the patient sitting opposite us is of the opposite sex. Now, from my experience again, and there is some research on this which also says that somehow men prefer to come to women therapists because there's a level of comfort they have talking about their sexual health and sexuality. Maybe it's homophobia, I don't know, but they prefer to talk to a woman about it. Now, if you are embarrassed yourself, you might, this is just a cognitive distortion that you have. You might think that, hey, does he think I am flirty, or does he think I want to talk about something that is not pertinent to the issue that I have presented in therapy? Now, all of these are barriers in your own head because you are self-conscious. Put it out there and start the conversation. The third one is we find a barrier to comfort is when clinicians believe that, I cannot be talking about sex unless they bring up an issue. And I can only ask if it has to do with procreation or if it has to do with dysfunction or disorder. Now, that too is a barrier. You can also ask a very simple, straightforward question: do you find your sex life satisfactory? Is it pleasurable? Or do you have any barriers that come in the way of you enjoying sex? It is not wrong to ask, it is perfectly fine. The fourth one is many clinicians, many doctors, because you're so super specialized, and many therapists who are not trained in sex therapy also believe that, hey, I cannot ask about something that I am not familiar with. I don't know enough. And I think we are never going to know enough. So the right source for us to learn from is the patient or the client themselves. Nobody knows better their sexual health, their sexuality than them themselves. So if we don't know enough, we ask. And if we think that, hey, this is beyond me, this is not something I can deal with or I can answer, we have to have the courage, the conviction of telling them that, hey, I'm sorry, but I don't think I will be able to deal with this. Could I refer you to da 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 da? I think that is the service we owe our clients, to be upfront if we don't know enough or if we believe that this is beyond us, to direct them to a correct source. And the last one, of course, barrier to comfort, is many doctors believe that if I'm going to be dealing with sexual health, which does not involve sexual dysfunctions or disorders, I don't really know how to go about it. I don't have a template. Hey, when I don't have a template, how am I going to be talking sex with my patient or my client? So I'm so glad a program like this, because you're getting a template. There are a zillion templates, but you're getting a template, a CBT template to deal with sexual health and talk about sexual health. So these are some, I've just picked a few barriers to comfort, yes, for a clinician. Okay, so in sex therapy with cognitive behavioral therapy, we take a very holistic approach, which means, of course, the bio bit, you guys come in again from the medical profession, but the psychosocial component is where we come in. But this is something even y'all can do. So we call it putting things in a context. So in CBT, we believe we cannot take anything in isolation and try to analyze it. We always must put things in a context. So, for instance, somebody who comes to you as a doctor, clearly then they're having a sexual disorder or a sexual dysfunction. If you are going to see it just from a medical point of view as a lack of performance or an inability to have an orgasm or whatever, please remember you need to place it in a context. And for that, you might have to ask questions regarding their psychology, their mental health, their emotional state of being, and even their social context. By social context, for instance, the socio-economic strata they come from or the religion they come from, everything plays a very significant role. Their levels of education, even a simple thing like do they live in a joint family or do they live in a nuclear family. So understanding the psychology and the social context of your patient will allow for you to assess your patient in a very healthy manner. So again, this is about cognition, yes. The second bit to take a holistic approach, keeping in mind cognition, of course, is to set very realistic expectations. If you are going to believe that you, by fixing their sexual dysfunction or by you fixing their sexual disorder, they are going to be able to have a very satisfactory sex life, then perhaps you have unrealistic expectations of yourself and they have unrealistic expectations of you, that you have a magic wand that is going to make them fit and fine to perform in bed. So set realistic expectations, please. The third one is provide accurate information. Again, it's the implicit model where we provide accurate information. And if you believe that you do not have accurate information to pass on to your client, please do them the service of referring them elsewhere to somebody else who you believe is competent enough to answer their queries or to deal with their presenting issue. So providing accurate information. The fourth one, of course, is what I said, coordinate with other professionals. But here I would like to add one more factor. If you sense when you do also a psychosocial besides a bio approach to assessment, if you find that there are other issues here, like a diabetic or, or depression or things like that, then hey, please also then refer them, because comorbidities play an important part in sexuality and sexual health. And the last one is comprehensive evaluation. Now, there are two schools of thought. One school of thought is that, hey, you get your patient alone, they might open up more about their sexuality and their sexual health. But there is also another school of thought which believes that if you were to call in their partner / wife, husband, spouse, whatever you want to say, their sex with who they have partnered sex, if you want to bring them in, then perhaps you will get another perspective. So that could also be an approach you take. But as I said, there are two schools about it. Do I see them alone and do I speak to them alone, or do I bring in the partner or the spouse or boyfriend, girlfriend, whatever you want to call it? So this is the holistic approach bit. The implicit model, I don't know how many of y'all are familiar with it, but this is a gold standard as far as sex therapy goes, where we believe that we must follow a model. This is the template that all of us must have. The first one, the P, of course, stands for permission. So, which means besides giving disclaimers before you start talking about sex, like me telling my client that, hey, may I know your sexual orientation? I'm sorry, I don't like to assume. And that is why I ask, is me giving a disclaimer here. But always ask for permission. So, for instance, in my clinic, when I finish with checking in with your body budget and physical health, I say, now I would also like to ask you about your sexual health. So ask for permission and then start. Don't just, slam them with questions about their sexuality and sexual health. The next one is the LI stands for limited information. It is always enough to give just that much. Don't overwhelm them with too much information about sexual health and sexual dysfunction, because you might actually scare them, you might actually frighten them. So, whatever the pertinent issue they bring up, give them an answer to that question alone, and wait if they are going to throw yet another question at you. The SNS stands for specific suggestions. Now, when you give them limited information apropos whatever question they have to ask you, then also it would be nice if they're coming back to you with another question that you give them a specific suggestion with regard to their question. And if you feel giving them limited information and specific suggestions are not really enough because they have more and more to ask and it is out of your league, then it is at that point you must refer them to someone who's more competent. And that is when we say intensive therapy comes in. Okay. I hope I'm not being too fast.
No, madam, it's perfect.
Okay, done. Okay, so when we talk about sexual health in CBT and in sex therapy, as I said, as doctors, you'll see a lot of sexual dysfunctions and disorders. We tend to see a whole host of other issues, some of which I'm just going to run through it. I don't think any of them, they're all self-explanatory. So the first one, of course, you guys come in, biological and medical factors. Then there are behavioral health problems like substance abuse, smoking, alcoholism. There are mental health challenges. Many clients come in with mental health issues, which are all comorbidities. Things like responsibilities of daily life can also affect your sexual health and your sexuality. Long hours at work, stressful work conditions, even mother-in-law problems are a concern, yes. Emotional dysregulation, not having what we call that thermostat to self-regulate emotions, can also impact sexual health and your sexuality. Then, of course, the sexual dysregulation, a typical example would be addiction to pornography. So there is dysregulation there. Then the way they view their body, how do they look at themselves? Aging. So here, menopause, I would especially like to mention. Then, of course, sexual secrets. I have some fetishes or I indulge in BDSM and I wouldn't want to talk about it. I have sexual secrets, can also impact their sexual health in partnered sex. And then I've got variant arousal, again, fetish back to sexual orientation conflict. Now, why I put the word conflict there is sexual health and sexuality. As a CBT therapist, I also find that there are many clients who have lived many married years as a heterosexual and have then decided to come out and come out to the world about their sexual orientation not being heterosexual, but either bi or gay. So sexual orientation conflict, and then of course, finally, relationship factors. Remember, I told you it's biopsychosexual. So one of the biggest, I think the most common issue as a sex therapist, CBT therapist, I see in the clinic is, hey, what do I do? Nothing is going to work. Nothing is going to make it possible for me to have partnered sex with my spouse because I don't find my spouse attractive anymore. That is the hardest thing. What do you do? There is, as I said, we have no magic wand to suddenly make their partner in sex attractive to them. So those are relationship factors. So you see, with sexual health and sexuality, we need CBT because a lot of things have to be addressed here, as you all say, between the ears rather than between the thighs. Okay, now I'm going to the next. So these are some of the common issues we see, yeah, besides what you all see of sexual dysfunctions and disorders. Okay, now we're coming to CBTs. Now that I've given you a really long-winded introduction, I'm coming now to CBT. So cognitive behavioral therapy, as I told you, has three components: thoughts, behaviors, and feelings. And we call it a triangle because all of them impact one another. So every time somebody, of course, I'm going to stick to sexual health and sexuality as the topic, yeah, the theme today. So assuming a person has a particular thought about, let's say, the act of sex, let us take a heterosexual person who is indulging in self-pleasuring. It's not partner sex, but simply masturbation. So if they are indulging in self-pleasuring, now they might, while it gives them a lot of pleasure, there might also be a thought, hey, what I'm doing perhaps is not good. So, which means the feeling, the emotion would be a sense of guilt. The emotion would be shame. And the behavior would be that they will try to overcompensate or perhaps avoid or perhaps even freeze. So, which means their behaviors could be self destructive. Now, because they feel very bad about what they are doing, the sense of guilt, the sense of shame, maybe even a sense of regret, overcompensatory behavior could be just to feel good again, they might go back to self pleasuring. Just a random example I'm giving you to show you how thoughts, behaviors, and emotions are all connected. And of course, as I said, the theme here is sexuality and sexual health, and therefore my example. So if we are going to deal with the three components of CBT: thoughts, behaviors, and feelings, we need to first remind ourselves before we talk with our clients using the CBT model. First and foremost, our clients come to us, in my case, as I said, not a medical doctor because you all deal more with dysfunctions and disorders, but someone like me, as a CBT therapist, I need to first put a meaning into their experience. So for me, it is not about performance and outcome. It is more about the experience and intent. And therefore, as a CBT therapist, I must first check in what are some of the thoughts they have in their head about their presenting issue. I must dive deep into that. And once I know the way they are thinking, then I lead them to, hey, if this is the way you're thinking about this, how does it make you feel and how does it make you behave? Like, for instance, as I said earlier, a client who does not find their partner attractive enough to want to have sex, perhaps the behavior is avoidance, avoiding having sex at any cost. Feeling is, again, shame and guilt, but also maybe happy. It could also be a positive emotion. So, for me to understand all of this is important. Therefore, if you're going to use the CBT model, please remember any experience your patient is talking about with regard to their sexuality or sexual health, please stop, pause, check in. Hey, how does my client experience the issue that they are speaking about and what meaning do they give it? So it is not merely about performance. The second one is, as CBT therapists, it's very important for us to understand that we are not going to be dealing with their disorder or dysfunction. Rather, we are going to be dealing with the person who has the disorder or dysfunction. There is a face, there is a human being behind the disorder or dysfunction. So, which means, remember, I told you the psychosocial aspect of it is very important for us to understand that. How does this person think? How does this person feel? How does this person emote? It's very important for us to understand the person behind the diagnosis. The third one is promote social change. For us to be using the cognitive behavioral template, it is also important to understand that dealing with sexual health and sexuality is not all about reactive and treatment. At times, we also need to be proactive. And, this is something Neeraj, I think when before everybody else joined, you asked me this question about sexual dysfunction, and I spoke about self pleasuring. Yes, and how it's a more common phenomenon among the male gender than the female gender. Now, I was just telling Neeraj this, that in schools, sex education is more about procreation rather than sex for pleasure. Like, so we need to ensure that we promote social change, being proactive rather than reactive. So if you, for instance, as a doctor, if you had a client who came in and let's take typically a woman who says that, oh, sex for me is painful and all of that jazz, and then you go into vaginismus, lubricants, da 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 da, and before which a simple question, keeping the CBT template in mind and fixing the psychosocial context besides the bio, it would be nice for you to ask the woman, hey, are you familiar with your own body? Do you self pleasure? Because if a woman doesn't know what pleasures are, if she is not familiar with her own vagina, if she has not kept her mirror down there and looked inside, and she has no clue as to how it looks, how is she going to be able to tell her partner in sex that, hey, this is what I like, or this is what I don't like, or touch me here, or don't touch me there? So we need to promote social change. So just asking a question and saying, hey, could you discover your own vagina? Why don't you, on your way back, pick up a hand mirror? Because unfortunately, our anatomy is, in such a way that you're going to need a hand mirror to look down in there. So could you pick up a hand mirror? Now you're trying to promote social change by trying to encourage her to get familiar with her own body, and you're being proactive rather than reactive. This is so that we don't conform to toxic norms. As the other issue that I brought up was menopause. Yeah, we have a lot of myths about menopause. Oh, that dried up woman and things of that sort. Hey, we need to change things. So we need to promote social change. So usually when a woman has menopause or perimenopause or postmenopause, we just assume sex is difficult. That's an assumption we are making. As a CBT therapist, an assumption would be a cognitive distortion. So you need to check, ask her, what's the quality of your sex life? Remember the 3 questions I asked? Are you sexually active? What kind of sex are you having? Penetrative, or do you get a hand job? Or does he go down on you? You ask. If you do not ask, they're never going to be able to tell you. And you might be surprised. She might say, yeah, I can't have penetrative sex because I'm so dry down there in spite of lubricants, but I love it when he goes down on me. Yeah, you got a little door ajar there. You can go in there. You can promote change. Yes? The next one is a change generated from within. And this, again, is a proposal. Just what I spoke about, asking them to do what it takes to bring about change for themselves, rather than having the expectation that you as a clinician will set it all right for them, or the person they are partnering in sex will set it all right for them. Ask them to take responsibility and ask them to do what it takes to improve their own sexual health. You're giving them agency, essentially. Again, CBT, cognition. Yeah, and the last one, of course, is for you to remember when you're using a CBT model, the idea here is that sex is about intimacy and not about manufacturing orgasms. If you are going to think that the entire sexual activity is based on having an orgasm, then I think you might be doing, again, a disservice to your client. So maybe you need to also inform them that as long as you can have physical intimacy, sexual intimacy with your partner in sex, as long as you are able to self-pleasure and have an orgasm, hey, you're on good ground there. You don't need, sex is not about manufacturing orgasms. So please remember that too. All right, let me move to the next slide. Okay, so if you're going to use a CBT model of cognition, behaviors, and emotions, then please remind yourself that my job is not to ensure my client is having pleasure, is aroused, and having an orgasm. My goal in therapy using the CBT model is to ensure that my client's self-esteem is better, higher. My client experiences pleasure and is also able to give pleasure if it's partnered sex, feels a level of intimacy with their partner, and is satisfied. with whatever that is. So, goals of therapy using the CBT model of cognition, behavior, and emotions, you must time and again remind your client that, hey, simply because you're not having an orgasm doesn't imply that your sexual health is poor. If it does not impact in a negative way your self worth, your self esteem, if you are having pleasure but not an orgasm, if you feel connected with your partner, and if you are satisfied, bingo, home run. That's good enough. So we need to change our mindset as to how we view sexual health and sexuality. All right, what's the next slide? Okay, so remember I told you thoughts, behaviors, and emotions. Now I just want to go a little into a little detail there. Yes, I'm going to just spend 5 minutes on each. So what are thoughts about? Thoughts as in cognition, yeah, the first word in CBT. So most often we find that people tend to think in negative ways. So we call them negative automatic thoughts. A lot of other people in this profession, like me, call it cognitive distortions. We all have them. Whether we like it or not, they automatically come and jam our brain and minds. Okay. So, what are some of the cognitive distortions we all indulge in? One is we tend to personalize. So, for instance, if I am having partnered sex and my partner cannot have an erection, I tend to personalize it. Oh, I'm not attractive enough to my partner. That's personalizing. It's a cognitive distortion. Another one is catastrophizing. So suppose my spouse and I cannot have, and I see many clients with this, yeah. If they're just married and they're unable to have sex, I have seen the couples, they have not consummated the marriage. I think the longest I have seen is 7 years, not consummated the marriage. Now, I'm talking about couples married for a year or two, but not consummated the marriage. They tend to catastrophize. Oh, because we cannot have penetrative sex, we need to divorce. Or because we cannot have penetrative sex, we will never have children. That's catastrophizing. Hey, that's when you go to medical doctors and they come up with solutions for your issues. So we find that cognitive distortions, catastrophizing. Then all or nothing thinking is another typical cognitive distortion that clients tend to think, oh, if I'm not having sex, then something is really wrong in this marriage. I need to end it and look elsewhere. Or, hey, I'm not getting sex in my marriage, and therefore I need to be having sex outside the marriage. So it's all or nothing. This is yet another kind of cognitive distortion. Another one is emotional reasoning. Emotional reasoning is when there might be a very rational problem there, but the person would rather like to look at it from the perspective of emotions. So, what would be a typical example of emotional reasoning? Okay, so let's take a man who indulges in substance abuse or alcohol. Okay, and we know that he's unable to, after he's been to the doctor and the reports have come in, and we know he has got an ED problem or an ejaculatory issue, and a large part of it is coming from his substance abuse or alcoholism. But he will emotionally reason, no, I don't drink that much, that is affecting me. My dick doesn't stand up, or I have premature ejaculation. It's not because of my drinking problem. He will emotionally reason and try to not only convince himself but also try to convince you, because his emotional voice says, hey, come on, you're not doing anything wrong there, and you don't need to stop your your abuse of alcohol or substance simply because you can't perform in bed. No, that's a separate issue. It's not because of my alcohol or drugs. So the reasoning is emotional, and they will argue with you. And simply for you to get through to them will be difficult. Another one is mind reading. Mind reading, a lot of clients do, and we as clinicians also tend to do. By simply observing the other person, we think we know how they are thinking, which is not true. Always ask. Always ask. And of course, overgeneralizing. Overgeneralizing, all of us do at some point or the other, or they're not having sex, so it's an unhappy marriage, or they don't know how to masturbate, they're never going to learn how to. That's overgeneralizing. Hmm? So these are some of the errors in thinking cognition. Next one, of course, is emotions. So with emotions, and this is a huge component, much as we don't like to give it any credence or give it a lot of attention, we need to. So if your patient comes to you and they are emotional, don't make it all about cognition. Also, please accommodate their emotions, which means simply because they're crying, do not assume they are sad. Again, it's you assuming. You need to ask, would you like to tell me how you're feeling about this? And let them, in their own way, try to express what exactly they are feeling. And you'd be surprised, there are many people who cry even to express anger. So, crying is not only about sadness. So always ask, give them the space, hold the space for them to be able to name their emotion. Do not make an assumption. Anatomy of an emotion would mean you dissect the emotion. So if the client or your patient says that, hey, I'm feeling angry, I'm really angry about my inability to have an erection, then you also need to ask them a few more questions. So you're dissecting that anger, you're asking them questions about the emotion. What exactly about it makes you angry? Do not assume that simply because his dick doesn't stand up, he's angry. No, he could be angry because he believes now everybody sees him as a very emasculated person, or he might believe that his wife thinks he's no good, and that makes him very angry. So please ask, dissect the emotion. Why are you angry? What about it makes you angry? And things of that sort. And then, as a doctor, as a clinician, it is your job to give them permission to feel. Please do not tell your patient, no, no, don't be angry about it, don't be sad about it. No, we cannot deny them that. Give them permission to feel, so, which means you tell them, hey, I completely hear you. I see where you're coming from, and I'm really sorry that you're having to experience this emotion. Just saying these words, you give them agency, you give them permission to feel what they're feeling. Don't deny them that experience, please. Yeah, and this is a bit of, yeah, feelings about feelings. So sometimes we can also have feelings about our feelings. So again, I'm continuing with the same example of this man who's got an ED problem or an ejaculatory issue, and here he is angry. He can also have a feeling about his own anger. Check in with that. So his feeling about his own anger could be that I don't have the right to be angry. Now, that's a thought in my head. What right do I have to be angry? I'm not satisfying my wife. I'm not a man. So he's having all these thoughts in his head, and therefore, the anger that he's experiencing, he has a feeling and a thought about the anger. And then there is shame. What's wrong with me? How can I be angry? I shouldn't be angry. I deserve it. And then there is self blame, there is regret, there is guilt. You see, so you can have feelings about feelings. Also, check in for that. It gives you a lot of insight into how your patient is thinking. So if you want to use the CBT template, you have to spare them more than 5 minutes. Be curious about your patient, please. And of course, but with emotion, because I'm a CBT therapist, we find that besides distorted thinking, when the feelings come in the way, here I am telling you, give them permission to feel and allow them to talk about your emotions. But the rider here is sometimes our feelings can make us feel better, but it can make our problem worse. So again, I'm going with the same example. Sorry, this man who is angry that he's not able to have an erection, and then he's feeling guilty about being angry about not having an erection. What does he decide to do? He decides to get very stern with himself and just completely avoid sex, completely avoid talking about it, and go about life like everything is hunky dory and he's more than man. Overcompensatory behavior, right? And so what happens? He is not even open to talk about it. So all the feelings he's having, while he thinks it's a solution to his problem, is actually compounding the problem. Because if you take the psychosocial setup, it could be that he has simply distanced himself from the rest of the family. He doesn't interact with anybody. He has withdrawn into a shell. So also understand feelings can, while make a person feel better, it can also make the problem worse. Okay, now we go to the last component of CBT, which is behaviors. Yeah, what kind of behaviors will you come across when you are talking to your client about their sexuality or about their sexual health within the CBT template? You will find this is again self-explanatory, so I'm not going to spend time on it. They might avoid situations that will call for them exposing their sexuality or their sexual health, like for instance, not married because I didn't want to be having sex, or alcohol, substance abuse. They might drown their sorrows about their sexuality, about their sexual health with alcohol and substance abuse. Somebody who's gay doesn't want to come out and cannot put up with parental pressure to marry because they cannot come out to their parents about their sexual orientation, might take to alcohol and substance abuse. Then concealing aspects of self that cause shame. Hey, I'm addicted to pornography, but I feel very ashamed to talk about it. Or I masturbate more than twice every day and I don't want to talk about it. And then I might just sit with the feelings of shame and guilt and all of that and simply not open up to the outside world. I had one client who was indulging in pornography and masturbation for almost 9 hours a day and he was chucked out of his job. And what happened, because of all these aspects that he was concealing from his family, he began to not step out of his room. So you see, just because you don't want to speak about it, you don't want anybody to know it, you start concealing it. And all the thoughts of shame and guilt in his head and all the feelings he was having allowed for him to indulge in this behavior of withdrawal. Yeah. Then, of course, procrastinate. Clients keep the problem till the nth hour before they seek help. Like I told you about the couple I have seen, 7 years of marriage and not consummated the marriage. They tried to fix it on their own. I don't know what they were thinking, but they kept it, for 7 years, and then they kept pushing it, pushing it, pushing it. And finally, it was too late when the woman said, "Hey, no, sorry, it's the end of the road for me." And then the man was, wanting to go and meet, but it was too late. She said, "You can do what you want, but I'm not sticking around." I was surprised she stuck around for 7 years. Anyway, keep seeking reassurance. This is another thing that we tend to behave in. When we have we self-diagnose that we have a sexual dysfunction or a sexual health issue, we tended to go to now ChatGPT, before it was Google, or we will, go to the internet and seek material there which will reassure us, give us what we call confirmation bias, tell us that which we want to hear. And then what do? We self-diagnose and we don't end up going and asking for help. So we seek reassurance from other sources rather than address the sexual health issue head on. Superstitious rituals. This you might be very familiar with. A lot of clients, to deal with their sexuality, sexual health, might take to superstitious rituals rather than getting professional help. One example I can give you here is of my client who came out because his family was forcing him to get married. He eventually came out to them that he's gay, and the mother then came to see me, and without exaggeration, she stood in my clinic and she cursed me, and she said, therapists like you will go to hell because y'all are promoting this kind of stuff. You're an evil woman. And she stormed out. And my client was already going through so much of shame and guilt. Now, I was also added on to that plate because he was feeling so apologetic for the way his mother behaved with me. Now, and what did she end up doing? She ended up taking him to some soothsayer or, somebody in the village. And they tied a lot of those colored strings on his wrist. And then there were many rituals. And then he had to drink many potions. But hey, he's still gay and he's happy. He's found a partner and everything is good today. But his mother has never come to terms with it. But he's left home and he lives by himself. So that's superstitious rituals. Then, of course, repeated checking behaviors. We find that a lot of clients with sexual health issues, which are about dysfunction and disorders, also tend to behave in obsessive ways. because they become preoccupied by their sexual dysfunctions and disorders. And of course, the last behavior we tend to see is they try to influence their partner. They will try and convince their partner that, no, no, this is in our best interest. But hey, you and I get along perfectly. We bond in so many other ways. Why is sex alone? I mean, marriage is not all about sex. It is also about, and then they will try and influence their partners, hoping that they will also get confused and come on board and not complain about the sexual disorders or dysfunctions they would otherwise have to live with. So these are behaviors. In conclusion, this is what I'm going to say. Yeah, today's sexual health and sexuality has not evolved. Most of us sex therapists believe that we have devolved it into a treatment of symptoms. We are not looking at, as I mentioned in the very first, second, or third slide, that it is about the psychosocial component also. It's not only about the biology. Yeah. So if you're going to treat symptoms for every sexual health issue your patient brings, it need not be a disorder or it need not be a dysfunction. It could just be a sexual health issue. If you are going to treat it as symptoms, then you might defeat the entire purpose of promoting proactively sexual health. So please remember, we find that today it has devolved into a treatment of symptoms because we have become so super specialized. Everything has a speciality. We find as sex therapists, we find that it is not so much disorders and dysfunctions. Again, as I was telling Neeraj earlier, it is more, we find so many cases where it is about low desire and no attraction for their sexual partner. How do you deal with that? We don't have pharmacology to deal with that. Yes. So these are the kinds of issues we now see. Medicalization of sex therapy. Yeah. I mean, take Viagra, take anything for that matter, which helps a man with a sexual dysfunction. We have medicalized it so much that the man believes that, hey, I have this and I'm good to go. But of course, they most often, as all of you know, they forget that they still need to be aroused. There still has to be desire and he still needs to be aroused. Then, of course, in conclusion, I would like to say this. It is, you can be the best doctor in town, you can have all the skills and you can have all the knowledge, but if you do not, or you cannot, or you do not know how to, or you cannot establish a rapport with your patient or your client, then all the knowledge and all the experience and all the skill you have is null and void. So spend that time to first build a rapport, and you'd be surprised at the way once you build a rapport and your patient knows they can trust you, you will be non-judgmental, they will open up to you. Fragmentation of sex therapy, everything has become, this fragmentation of sex therapy. I had this client who comes, of course, from your field, gynecology, and she opened my eyes to it, and she's sent me a few forwards about it, some papers, of course, too technical for me. I'm not a medical doctor, but nevertheless, I tried to read them, which spoke about fragmentation of sex therapy, fragmentation of fertility, and all of that. And so much so, there was this one very interesting paper she was talking about, which said that today making babies has moved to the lab. With fertility treatment, fertility clinics, and all of that. And it's a matter of time before, because it is a very controlled lab atmosphere, people will decide when they want to have a child, how they want to have a child, of what gender, how the baby looks, and all of that. And they will simply go to the fertility clinic and get it done. It's coming. It's around the corner. Maybe in the next 5 years itself, that's going to happen. Every time I want to have a baby, I go to the lab. So sex is then left just for pleasure. And that is why you and I need to be able to talk about sex for pleasure. And we are going to find more and more of our patients coming to us, or our clients coming to us, not to talk about wanting to have children or talking about their sexual dysfunctions and disorders. Hey, doc, how do I get pleasure? So be prepared for that. It's happening. So the last one, of course, the lack of training. So I'm so glad you all are here, because I just gave you all a kind of a sneak peek into what CBT is and how to approach it using the cognitive model, so that you can start establishing a rapport cognitively with your client. In your case, patient, of course. Yep. That's it. I'm done. So I go back to this and I stop sharing the screen. Stop
Thank
sharing.
you.
Is this
Thank you
okay?
so much, ma'am. It was
Thank you,
very
madam.
much interesting talk. Neeraj Yadav, sir.
So yeah, sir, madam, I have one question.
Yes, please.
Suppose patient is having a orgasm problem.
Yeah.
Suppose, right? So, according to what I understand, Kate, we are shifting from performance to pleasure base
Mm.
in CBT. So, are we dealing with the orgasm problem, or just we are trying to convince the patient that your pleasure is more important than the orgasm? So, what is your
Are you
take on it?
talking in partnered sex or in self
Yeah,
pleasure?
yeah, it's in partner sex, yes, madam.
In partner sex, it can also be about intimacy, right? Being touched, like sense focus. The
Mm-hmm.
last bit is about penetration, orgasm. In the beginning, it's about learning to touch, learning to feel pleasure. So, I think orgasms are overrated.
Yes,
It's not the end goal of sex. It's about feeling pleasure by touch, and by touch, of course, your hands, your mouth, your sexual, your penis or whatever. Just experiencing pleasure by touch, the journey, the act by itself, not the outcome. So to say that simply because I do not have an orgasm, it doesn't mean I'm not pleasured or I'm not satisfied or I'm not enjoying sex would not be right. Right? It's our job to inform our client about that. Again, this is a myth that we have passed on, right? The act of sex means it must end in an orgasm. And that's not true. I hope that answered your question, Neeraj.
yes. Uh, so, this cognitive behavioral therapy has role in every sexual dysfunction, or it is only based in certain part of the sexuality, or it should be effort to whatever the sexual disorder is there, maybe low desire or orgasm, or it is a dyspareunia or vaginismus. In all type of dysfunction, it has a role. CBT.
See, when they have a sexual dysfunction or I mean, when they if they come to us first, yeah, and if they have a sexual disorder or a sexual dysfunction, we of course the first thing we do is send them to y'all because we need a medical doctor to look at them and give us a diagnosis. And then most often they come back saying that hey, the doctor's given me an all clear, there's nothing wrong with me, and that's when we come in, right? Now, if they are not indulging in partnered sex but is them pleasuring themselves, then we deal with interventions. We have certain exercises we give them. Now, if it's partnered sex, then of course, sensate focus is the gold standard we give them in partnered sex. So we have interventions for everything. As I said, it's a implicit model. So we first try giving them a specific suggestion, limited information, and then if we find, hey, this is not working, then we give them some more. But we don't look at it as a dysfunction alone. We look at the person behind the dysfunction or the disorder. We try to understand that too.
Dr. Apurvadatta, sir, do you want to add something or comment?
Yeah. First of all, ma'am, thank you so much.
There are question in chat box, Sama. You can
Yes.
just.
Yeah. So first of all, thank you so much, ma'am, because we are always getting confused what is cognitive behavioral therapy, even as a gynec. So, ma'am, it's really difficult for us to, give this, sexual therapy to our patients. But today, really, we have cleared each and every doubts of the cognitive behavioral therapy. For that, thank you so much for that. Ma'am, one thing which I find being a gynec, because I'm also practicing sexual medicine. Is there when the patients are coming and they are not in the first setting, they are usually not much open up with us about their orientations, about their problems, and because many times people are thinking that we are judgmental, and probably that will be the main thing. So, ma'am, how to deal with that? Because it's really very much difficult, and first time when the patients are coming, we are just treating them, and the second time their history is changed. because then the second setting they are thinking, yeah, now this doctor is know about the my problems, now he is okay, now I can open with my doctor. So ma'am, how to deal with that? This is one, I think most of the gynec or other people might getting this type of problems. So just I want from you, ma'am. Yeah.
I can talk about my personal experience because I'm a gay affirmative therapist. I have enough in my clinic to show that. Because trust me, anyone from the LGBTQI plus segment of the population, when they walk in, they will spot it. And the moment they see it, they feel reassured that, hey, this is a room I can open up in. So even your all of you gynecologists could put up things in your clinic space. It doesn't have to be about the anatomy of the body, or it doesn't have to be about baby pictures. It can also be about sex for pleasure. It can also be, the anything to do with the LGBTQI plus. Put up something in your room that if people look at, they know, hey, this is a place that I can open up. This is a place that will accommodate me. You need to first put the sign out there so that when they walk in, they will see it. And that's going to help you break ice with them, right? Make it a friendly room for them when they walk in.
Absolutely. I think, ma'am, this is a very fantastic idea.
Thank
Because
you.
as a gynec, like we have a lot of, like contraceptive, we have a different methods. It is in the waiting area and other things like anemia, what to do and not. We have the pamphlets also. So probably, I think that's a very, very wonderful idea, ma'am, that by knowing that, yes, they will have some idea that, yes, this gynecologist, this doctor know about my problem. So thank you so much, ma'am. Thank you. And
Welcome.
thank you for the
So,
power. I mean,
Thank you.
yes.
Ma'am, we have a few questions from the delegates, ma'am.
Yeah.
yeah,
First
before that,
question.
Sama, 1 minute, 1 minute.
Yes.
Sunita madam, one question. Suppose in small center there will be no qualified psychologists who can handle the CBT therapy or any sunset focus therapy.
Yes.
So in that scenario, how we can help that such patient, because it's not available to every places
Yeah.
qualified psychologist.
I hear you, Neeraj. Remember, I spoke about the implicit. You give the limited information, specific suggestion, and if you feel is beyond your league, they're going to need more help, refer them out.
But in small matter, it's not possible, na madam. So
If there are
because
online,
in
but there are online, right? You don't.
okay,
So many online sex therapists are there.
okay,
Yeah. So you now everything is available on the computer. You can direct them, but just give them the right source, not a quack or someone who's going to.
yeah, that's the
Yeah, that's the thing. That homework
Right.
they have to do, and you can always guide them to an online session. Yeah.
Okay.
yes,
Okay,
ma'am,
ma'am.
yes, ma'am.
So first question is like, do you find better outcomes when CBT is used as a standalone therapy or when combined with pharmacological or hormonal treatment?
Oh, definitely combined. Definitely combined. Yeah, especially in cases of no, not. I wouldn't say especially. I take that back. Not only with sexual dysfunctions and disorders, anything. Like for instance, again, I can only talk about my professional experience. I have a client who's obese, and so she's got body image issues. So she not only goes to her endocrinologist, she's under treatment there. She comes to me to speak about her sexual health in therapy. A large component of our sessions are about her sexual health. She also goes to a gynecologist because of her irregular periods and all of that, which also the endocrinologist is dealing. So we work as a team, right? It's never one person alone. So she is on medication, she is on therapy. She also goes to a trainer. She's also with a dietitian. It's a holistic approach to it.
Right, ma'am. So the next question is like, how do you decide whether the issue is psychological and CBT oriented or whether it needs more of a medical or hormonal intervention?
Well, now suppose they come and suppose it's a male and he tells us he has an ED issue. He knows best, right? It's his penis. He knows best. Now, once he says it's an ED issue, I'm not a medical doctor. So I will immediately, the first thing I'll tell him is, hey, could you go to, and then I recommend a doctor, depending on which city he is. I say, could you get an all clear from them and then come back? That's the first thing. And if it's a woman, and if she tells me that at the point of entry there is a lot of pain, I can't deal with this. Then I tell her, please, could you go and, speak to a gynecologist, check in, get a diagnosis, and then we'll take it from there. So then, of course, then the bits of the gynecologist also encourages her to start using, a dilator and lubricants and medication, Botox, whatever. The doctor does all of that. But to deal with the shame of being unable to have sex, hey, that's when she also comes into therapy. So we know there are many things are beyond us. We immediately first refer them to get an all clear from a medical doctor, and then we deal with the other issues.
Okay, ma'am. So in the next question, they want to know that in your clinical experience, what kind of sexual dysfunctions respond best to CBT? For example, vaginismus, premature ejaculation, or low libido.
Low libido, I would say, if you give me these three options. As I said, we don't have a magic wand. We don't have a magic wand. And how can I measure how successful I am? Because my client might lie to me. My client might not might conceal from me. So, hey, how many times have you been able to get an erection, or how many times have you been able to ejaculate on time with your partner? Uh, they can fib about the statistics, right? So I'm not going to know how successful or I have been or not been, but depending on what they tell me, I choose to believe it. As long as the quality of their sexual health is improved and they are satisfied, I don't focus on performance.
Okay, ma'am. So, as your experience says it all, but people want to know that if a patient is very much having hesitation, which is a huge barrier, and how you deal with those patients to make them comfortable enough to engage in the CBT sessions openly.
Remember, I said the first intake form? In the very beginning, I speak about it, and then I get a rough idea how comfortable they are to talk about it. But honest to God, not one client so far in the 10,000 plus hours of therapy I have given, not one client has refused to answer all three questions. Not one. So they are that ready to talk. And we, as CBT therapists, believe you don't ask, then they don't tell. So we must ask so that they tell. And nobody is actually shy to talk about it. Of course, we have to follow a certain decorum. If they have come with their parents, for instance, you don't ask them these questions. You stick to all the other questions and then you send the parents out and then you ask them. Or if you think that, their sexual orientation or their gender identity could be something you need to dive into, but they have come with their partner or their spouse, then be sensitive. We don't ask in front of them. We send the partner out, we send the spouse out, and then we ask the question.
Okay, ma'am. So the next question says if you're planning for a CBT session and as all the sexual dysfunctions have overlapping causes, how do you balance the biological, psychological, and relational factors when you're planning for CBT session?
The psychosocial component will come to me, but the bio component will go to the doc. I may perhaps I have been fortunate, I don't know, but I find that a lot of doctors, they call and they ask because they also want to know the mind, as I said, the person behind the diagnosis. There are many doctors who like to send me a message saying, Sunita, you have met them. What do you think about their mental state? Or are there any issues I need to know about them that they perhaps are not sharing with me? So I find that if we professionals are able to talk to each other about our patients and our clients and transfer relevant information with the intent of helping the patient, that will really work wonders, right?
And
Actually,
Sunita madam, how many sessions will be usually you required for any dysfunction, or how will you go about the sessions? It is weekly session, or how you go about it?
I usually see my clients once a week, and we try not to go beyond 6 to 8. But of course, not all my clients deal with sexual health issues, right? I also see clients with other issues. So somebody who has a personality disorder could be coming to me for years, once a month, once in 3 months. So it really depends. But with sexual health issues, anywhere from, I would say, 6 to 8.
Okay, so it is weekly session or monthly
Once a
session?
week, once a week. We like continuity.
Once a week session.
Yeah. We like to finish it 4 weeks, or on an average 6 to 8, but there are also 4 weeks. I've even seen clients one session because it's a very solution focused, we call brief therapy. They just come with that issue and they get a solution from you for it, and then they go back and they don't come back. So I like to assume it has worked. So even one session, but on an average 6 to 8, once a week, every session is for an hour.
So usually 1 hour. Okay.
Yeah.
Each session is about.
Yeah.
Actually, Neeraj sir wants us all gynecologists
Yes,
to
Sama.
have a CBT, and these all things to be known to us
Mhm.
to treat our patients with somewhat zeal. Along with gynecological problems, we should deal with some sexual health problems in a basic level, bolke. But delegates wants to know that do you think CBT should be a part of medical or gynecological training, since so many sexual complaints have psychological roots?
Okay, I'm going to say two things about this. Yeah, one is as a CBT therapist. Okay, no, I'm not talking only about sexual health. Yeah, as a CBT therapist, now this is my personal opinion. I think there are everything that we see in the clinic will boil down to two factors when it comes to relationships. One is money, and the other one is sex, whether we like it or not. Okay. So, since sex, I mean, we are all not financial advisors, so this is the difficult one. But when it comes to sex, if all of us therapists, not all therapists are trained to deal with sexual health issues, yeah? So, if all therapists are trained in sexual health issues, we are doing our client a huge favor. So, if we are going to say that about therapists, I'm going to say this about medical doctors too. If you all are trained to deal with sexual health, not for procreation alone and not about disorders and dysfunctions alone, but also for pleasure, imagine what we can do for the mental health of every patient of ours.
True,
So,
ma'am.
sure, everybody should be trained in it, in the helping.
Sunita, madam, is there any role of CBT as a premarital counseling? Suppose any patient.
Yes,
patient
we do.
Yeah.
We do. Yeah, we do. Because
Okay.
as I was telling you, right, this the most common problem is sexual inexperience in adulthood. So a lot of clients then come in before their marriage. So by our definition, sexual inexperience in adulthood would be a man or a woman who's not had a sexual encounter or a sexual experience in partnered sex with before marriage. And then definitely then they come in because either they find that both of them are inexperienced and they would like to talk about it, or they find that the other is inexperienced and would like to then speak about it and get some what we call psych education about the same. So a lot of couples do come in for premarital counseling. Yeah.
Yes.
But today sex is not between married couples alone, right? Yeah, with the millennials and with the Gen Z, they're not married. They're all sexually active. Most of them, I would like to think, are sexually active. Yeah. So a lot of single people too, I see. So it's not all about premarital counseling. A lot of unmarried people who come with sexual health issues.
Yes, ma'am.
And Sunita, madam, relationship issues also covered under CBT, or it is a different thing?
No, same. The template is the same, right? About cognition, behaviors, and emotions. Of course, and then from there we go into other areas, but essentially the template is the same.
Ma'am, next question says, do porn and AI affect sexual health?
Everything in moderation is fine. Everything in moderation. No black and white thinking, all or nothing. Remember cognitive distortion? Yeah, everything in moderation.
Yes, ma'am. So next question is like when the husband is a nymphomaniac and the wife is asexual but agrees to sex for the pleasure of the husband.
Sorry, you said when the husband is a nymphomaniac,
Nymphomaniac,
okay, and the wife is a
asexual,
okay, got it.
but agrees to have sex for the pleasure of husband, and how to proceed as a doctor, how to deal with this case.
Well, I think you should refer them to a therapist, a sex therapist. This might be beyond you because you have to deal first with his issue, and then you have to deal with her issue because she is asexual, plus the what we call in CBT, again we call it self-sacrificing. That's a schema. The word here is schema. If she has the schema of self-sacrifice, where she believes essentially that she has a moral and ethical responsibility towards her husband and she must satisfy him in spite of me being asexual, I have to satisfy him. So you see, there are many issues we have to deal with. It would be best then for you to send them, the couple, for therapy because this might be beyond you. It's not a medical disorder or dysfunction, right? It's up here.
Okay,
Same
ma'am.
thing, madam, about the desired discrepancy between the couple.
I'm sorry.
Desired discrepancy.
Yeah,
Yes, ma'am.
desired
Desired
discrepancy.
discrepancy.
Yeah, the same thing.
Okay.
Please, you need to send them to someone who's trained in sex therapy, right? Using the CBT model.
Okay. So the next question is like pharmacological, ma'am. So I'll go to the next one. If
Pharmacology, I'm zero.
okay, ma'am. So the next question is like I had a patient
It is
narrative
only about CBT, na?
to
But yeah.
indulge.
I'm not a medical doctor. I don't know anything about medicine.
Yeah, they were asking how to increase sperm motility apart from vitamin E and levocontin
Just
bulkers.
put up the question which is relevant, Suma.
Yeah.
Just put question which is relevant.
The next question is like I had a patient. He used to indulge too much in self pleasure. Now he is infertile. Semen analysis showed normal count but reduced motility. I prescribed multivitamin and antioxidants. So this also a little bit advised stress reduction and weight reduction. What else can be done, madam, to increase sperm motility naturally? This also a little bit of pharmacology.
Yeah.
So this completes all the questions in the chat box, ma'am.
No, but I'm just going to run with that question again, a
Yeah,
little bit of that question about, you said masturbating too much.
yes, self-pleasure, masturbating.
Yeah. So here's the thing that, as a sex therapist, I will say, who is to say how much is too much? So if your patient comes and says, I masturbate too much or I self-pleasure too much, you need to ask more about it. Be curious and ask, because with all the myths and disinformation about masturbation, maybe even once a day, they are feeling so shameful and so guilty about it. They could come and tell you that I indulge in it too much. So please use this little door, which is ajar, where they've told you that I masturbate too much. Get into it and ask how much is too much and speak about it. And that has no connection with the mortality of your sperm, right? So that's a point for you to give them some psych education.
Okay, one question was there, ma'am, in our WhatsApp group a few days ago that a couple was in love for 5 years and after marriage, husband had some decreased feelings on wife. He had some means ejectile dysfunction or something, ejaculatory dysfunction or erectile dysfunction with his wife actually. So they were in relation in 5 years. It was okay, all okay. But after marriage, erectile dysfunction was noted. So if they go for CBT, is any help for them?
First, he needs to go to a urologist or a sexologist and check about his medical problem. It cannot be because he doesn't find his wife attractive anymore.
Yeah. Yes, ma'am. Actually, yeah, we told we have to take a complete history first. Everything should be ruled out. Then we need to go for CBT. If at all, how it will help them, ma'am, CBT?
CBT comes, the first thing we need to remind him is if you're not able to ejaculate or you're not able to, either you have a delayed or premature ejaculation, or if you have an inability to have an erection, is not because your wife is not attractive enough. You need to take responsibility for it and do what must be done. to deal with the issue. You can't lay the blame on her, right? We need to take responsibility and do for ourselves what we must. Because again, then how is the wife going to end up feeling? She's going to personalize it because she has now come to believe that it's because I'm not good enough, I'm not desirable enough, that my husband has a sexual dysfunction. So we have to deal with a couple together in therapy.
Thank you so much, ma'am.
Sunita madam, suppose one couple is there where husband is very much interested in the oral sex, but the wife always refuse for the oral sex. So they have an issue regarding that. How will you deal with them?
Well, in this, I would give them some behavior exercise, one of which, of course, if she does not want to give her husband her blowjob, one is I would encourage them for her to try it with a condom. There are these flavored condoms. I would encourage her to try it. And she says, no, I still gag, or, it's not my scene at all. Another thing I could is ask him to not ejaculate into her mouth, or perhaps maybe even we try what we give. One solution is about using an ice cube. We tell the woman to keep a cube of ice in her mouth. So there are these specific things for these things. As I said, it is to that problem, limited information, specific suggestion. And if it's still not working, then intensive therapy. Then I have to speak to the husband about, if you know she doesn't like it, and if you know that she has tried all this for you, and in spite of which she's reluctant to give you a blowjob, then perhaps you should do a rethink about it. Now that's the intensive therapy. That's when we step into that area.
Sunita madam, are there any exercise that comes under the CBT, or it is purely counseling based?
These tips are about from sex therapy. They're not cognitive behavioral therapy. Cognitive behavioral therapy is more to do with, as I said, cognition, right? But also because I'm a sex therapist, I gave you some interventions from sex therapy. This is not CBT.
So sensuous focus, does it come under the
sex therapy,
CBT, or it is a different?
Sex therapy.
Okay. Sindhu Lakshmi, do you have any question? Okay.
Yeah, please.
Is there any other question from the chat box? Neetu?
Done. Covered, sir.
Sir, all the questions from chat box are covered.
Okay.
Sindhu Lakshmi, vote of thanks.
Good evening, everyone. It's my pleasure to deliver the vote of thanks for today's session, Sexual Health Ki Pathshala, episode 2. On behalf of the organizers, I extend a heartfelt gratitude to our distinguished speaker, Ms. Sunita Menon.
Yeah.
Ma'am, for your insightful talk on cognitive behavioral therapy. Ma'am, you clearly explained how cognitive behavioral therapy can help individuals to understand the connection between thoughts, emotion, feelings, behavior, and how it can be applied to enhance the mental and sexual well-being. Ma'am, your practical examples and compassionate perspective has made the topic relatable and inspiring. Thank you, ma'am.
Thank you for your kind words. Thank you.
A special word of thanks to the SexMed Connect team. Thank you, Neeraj sir, for your continued vision and promoting this educational programs. My gratitude also goes with the participants. Your presence and involvement has made this session very meaningful and successful. Thank you, MediSage Committee, for providing a wonderful platform.
People also.
For providing a wonderful platform and reaching out to doctors across the country and help in exchanging the ideas and thoughts. Let us carry forward the insights from today's session and continue to create a safe and informed and empathetic services for conversations around sexual health. Hope to see you all in the next session of Sexual Health Ki Pathshala. Thank you.
Thank you, Sunita madam.
Thank you for the opportunity. Thank you so much for the opportunity.
Thank you so much, ma'am. Thank you. It's really a wonderful session and an eye-opener session. And always thank you to Neeraj sir, our backbone and Jyoti Punj of ours. Thank you. And thank you, Sama and Dr. Shindu. Thank you so much. Thank you.
Thank you very much. May I leave?
Everyone. Bye.
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 Thank you, everyone. Bye.
Bye. Thank you.